Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. I'm coming to you from Southern California. My name is Terry Fletcher, and we are going to talk about medical billing and coding today. Basically, what is the difference? And just making sure that you understand that they're not the same thing and what's involved in each. And I really wanted to bring it back to the fundamentals of what billing and coding is. I get a lot of questions with regard to both topics. I know when I'm at a live seminar or conference and I'm talking to staff members, talking to physicians, and one of the things I do is I poll the audience and I say, how many billers are out there? And I get a bunch of hands raised. And then I have how many coders are out there? And I actually usually ask the question in reverse. And coders raise their hand. But I don't always see the same hands raised. Sometimes I do, sometimes I don't. But if you're a coder, you're a biller. I'm sorry, you are. If you're a professional coder, meaning the physician side of coding, I would assume, and I'm going to make this assumption, even though they say you shouldn't assume, that you want to know with what you code and what you give the billers to process for that it turns out into a reimbursed service. So you want to see the full circle process. A biller isn't necessarily a coder, but they need to know actually who their coders are, have a decent relationship with that, and really understand the process. But medical billing and then medical coding, they are two different things, and we're going to dive into the differences and then how they intersect and they can work together. Not only am I going to show you the positives, but I also want to focus on billing errors versus coding errors, and then what we can do to make sure we're just more precise in our coding processes so that we can, maximize our reimbursement and be really good at our job. And I also want to comment on how to transition to be a coder. I got a really nice direct message on LinkedIn, and I love hearing from everybody. And one of my followers basically said, Terry, can you talk about maybe on your podcast how to go from how I can be a coder? And I didn't realize that she was a biller first until I looked at her profile. And so that actually makes it a little bit easier than starting cold in the field. But I will talk about that a little bit, because I think that sometimes in certain practices, I don't want to say it's a step up, but but being a coder definitely has more responsibility from an accuracy standpoint than a biller does. Not saying that a biller doesn't have to be accurate and, efficient in their job. There's just a different type of accuracy that's necessary. And I'll give you the differences there. But first, before we get started, the Codecast podcast today is brought to you by Healthcare Executive Network. That's the fastest growing network community for healthcare executives and their trusted partners, healthcareexecutives.org. Keck Medicine of USC, 500 plus internal renowned doctors at a leading academic medical center, keeping you healthy and doing what you love to do, keckmedicine.org. And we have a new sponsor, which we really appreciate them joining our genre here and our Codecast, and that's Children's Hospital LA, spreading the word about work that prevents the spread of disease and heals sick and injured kids, chla.org. So we're happy to have all of you here, and we're just really, really appreciative, not just of our sponsors, but of our now, and I'm going to brag a little bit, of our over 15,500 listeners and downloads. Thank you so much. We just really appreciate where we're at in the industry. We are, again, on iTunes, and we are the top billing and coding and business genre podcast. And so that just makes me really happy when I get to see that. And when you search it out, we're in the top 10. Actually, we fill out all the spots in the top 10. Different episodes fill it out. And then after that, we actually are number 12, number 17, number 19. So we're definitely doing something out there that's good. So we appreciate everybody's listening in and supporting our efforts. So thank you again for that. Never want to be remiss in that. And my team. So I really like my team that I have of producers, music producers, and all of that. You're also going to maybe hear a little bit some refreshed sounds now that we've been on the air for about 8 months now, a little over. And so we're going to maybe our intro music, we're going to freshen that up a little bit. So I'll be getting my music producer, DeSasson, on that. And then we're also going to possibly add some fun things later on. So just know we want to make sure we keep it fresh, that you're always wanting to, turn it on when you're either in your car or you're at work, and you just really find it as a tool that you can use in your everyday processes. So let's get started. So what I want to take a look at is, again, exploring just really the fundamentals of medical billing and coding. So, they're really the backbone of any kind of healthcare revenue cycle, ensuring payers and patients reimburse providers for services delivered. But medical billing and coding, even though they translate a patient encounter into the languages used for claim submission and reimbursement, they are separate processes. They're not the same thing. So medical billing can involve sending claims to insurance companies and tracking these claims until you receive payments. Medical coding is more of the process of translating diagnoses established and procedures rendered to patients in a set of precise codes. And they're both crucial to receiving payment for healthcare services. But as we look at it, medical coding kind of in a nutshell, it really involves extracting billable information from the medical record and clinical documentation. While medical billing, on the other hand, they use those codes to create insurance claims and bills for patients. So they creating claims is where medical billing and coding kind of intersect. And that's what forms the backbone of your healthcare revenue cycle. But the process doesn't start in the billing office. So the process actually starts with patient registration and then ends when the provider receives full payment for all services delivered to the patients. Now, payment means not just money. It also means you might have a provider discount. You might be dealing with reductions in services because, again, you're on a panel. It also means that you may be an allowable versus what was actually paid. It also means deductibles, which are patients out of pocket, co-pays, which are just specific to the practice itself. And so you want to make sure you're understanding that the medical billing and coding cycle can take anywhere from a few days to several months, depending on the complexity of services rendered, management of any claim denials, and really how your organization collects a patient's financial responsibility. And I've talked about this before because we want to make sure that we also give patients every opportunity to pay their bill online if they can. A patient portal is going to be pretty needed, and especially nowadays as we're getting more into the electronic genre of reimbursement. So ensuring provider organizations understand the fundamentals of medical billing and coding, and this can help providers and other staff really operate kind of smoothly as they understand the processes. So what is medical coding? Okay, so this starts with a patient encounter in a physician's office, could be hospital or other kind of delivery location. I know you've heard me talk about telemedicine as well. So when the patient encounter occurs, then your provider, physician, mid-level provider, even a technician, if you have physicians in the office, they detail the visit or the service in the patient's medical record, and they need to explain why they furnish specific services, items, or procedures. So accurate and complete clinical documentation is going to be crucial to pulling and extrapolating these codes. What I'm sure everybody's heard, especially if you're a coder on the listening in, the golden rule of healthcare billing and the coding department is, if it's not coded, it's not, or if it's not documented, it's not done. Another way to put it, do not code it or bill it if it's not documented in the medical record. So I don't like the phrase, if it's not documented, it's not done, only because it could have been done and the doctor just didn't complete the record. So what you want to look at is that don't code or bill for it. Don't report it if you cannot support it within that record. So I know that means the same things. It's a little bit semantics. But for any of you that are also certified coders, that's one of our golden rules in compliance, and we have to adhere to that. So providers use that clinical documentation to justify reimbursements to payers. When a conflict with a claim arises, then that's how we can justify that service. If a service is not sufficiently documented in the medical record by the provider or by the staff of the provider, that's the clinician, You can face not only a claim denial and write-offs, but there could be potential healthcare liability investigations. There could be a fraud audit. There could be something that the payers may think the patient, you were reimbursed for services incorrectly because either it was not documented in the record, missing in the patient's data altogether, or was not complete. So, for example, once the provider discharges a patient from a hospital or the patient leaves the office, a professional medical coder, and I'm not saying certified, I'm just saying somebody who has the role of coder, they review and analyze the clinical documentation to connect services with CPT procedural codes and also the ICD-10 codes. And so when they're looking at these, and those are basically procedural, diagnosis, charges, and then also there could be professional or facility codes as well. Several types of code sets are used for different purposes during the process. So I mentioned ICD-10 codes. So those are diagnosis codes. Diagnosis codes are key to describing a patient's condition or injury, as well as social determinants of health and other patient characteristics. So the industry uses they call it the International Statistical Classification of Diseases and Related Health Problems, 10th revision. That's the ICD-10. For professional services, you're using the CM. That's the clinical modification. That's for diagnostic and physician coding. If you see PCS, that's procedural coding system. That's for inpatient procedures performed in the hospital, not physician. Those are facility. So I don't want you to get it confused there. In the ICD-10 code set, there's more than 70,000 unique identifiers alone. The ICD coding system is maintained by the World Health Organization and is used internationally. That's all over the world. CMS transitioned to the industry to the ICD-10 in 2015, as you know. I mean, they tried in 2000, but they said they were going to put it on hold. I think they thought everybody's computer was going to blow up when we hit the new millennium, and it didn't. And they're like, oh, I guess we need to move forward with this since everybody else has. But the codes indicate a patient's condition or injury, where an injury or symptom is located, and if the visit is related to an initial or subsequent encounter. For some codes, we have now laterality, which shows the right or left side of the body. We never had that before. Age-specific codes. When I talk about, the subsequent or initial encounter, you've got some seventh digit characteristics if you're a coder, basically saying, did this happen initially, or was this the first time this ever happened? Was it the subsequent time it happened? Was it a delayed reaction? So delayed treatment. If you're dealing with fracture care, oh my gosh, you've got all kinds of things when it comes to different coding systems. But coding supports medical billing by explaining why the patient sought medical services and the severity of their condition or injury. So that's really what we're going for when we're dealing with ICD-10 coding, the diagnosis codes. Then procedure codes, and those are considered CPT, current procedural terminology, or HCPCS codes, Healthcare Common Procedural Coding System. I bet some of you didn't know what that was. I actually have that. I teach a boot camp. I actually did today and yesterday on certain specialties. Today and yesterday was cardiology. I have one coming up in the fall for orthopedic. They're 2-day webinar conferences if you can't get to a webinar. And then I have one coming up at the end of the month for gastro. But basically that was one of my questions because I give a quiz and it says, what does HCPCS mean? And people are like, oh shoot, we know what ICD-10 is, and we know what CPT codes are, but we don't know what HCPCS is. So again, Healthcare Common Procedural Coding System. It's really focused more on what Medicare says and really kind of what they do. But AMA publishes the CPT coding guidelines each year and to support medical coders with coding specific procedures and services. There's also modifiers, and modifiers indicate if providers performed multiple procedures, why a service was medically necessary, where on the patient medical record the procedure occurred, where in the patient's body something occurred. There's vessel modifiers if you're cardiology. There's modifiers to say that you had more than one service on the same day. So there's all kinds of different things that modifiers can do as well. When you're dealing with HCPCS code, because those are really, health insurance information, or I should say the Health Insurance Portability and Accountability Act, HIPAA, requires the use of HCPCS codes, which is kind of built on the CPT coding system. But CMS they require it, but third parties don't always tend to use them. So private payers like CPT, CMS, and third party require HCPCS. So it just depends on what it is. But you want to know that generally everybody's going to use the CPT coding system. Then you have charge capture codes. So this is coders also can connect physician order, entries, patient services, and other clinical terms with charge masters. And what a charge master is, it's really a hospital term, but it's a list of the organization's prices for each service offered. So I see those a lot. I'm doing a really big audit right now for a really big hospital in the Boston area, and they sent me all their charge masters. And it's just so tedious going through the whole thing because I'm having to link that to services and then link it to inventory control. And then you have professional and facility codes. So if you're dealing with the medical record so professional codes are physicians, what they do. Facility codes is the hospital, what they do. And not everybody is a facility coder and not everybody is a physician coder. I would just venture a guess that physician or professional coders are probably more plentiful than facility coders. And so you just be aware of that. It just depends on what you want to do with that. Sometimes there are practices or facility coding and professional coding. They're trying to get this to be one platform. I know that the University of California, San Diego Healthcare, they implemented a single path coding, which brought professional facility coders to one platform, but they're pushing codes from professional billing to facility through a charge router. So it's not the easiest or the most straightforward process, and there are some failure points in it. But with professional facility coders working kind of in silos, there was some duplicate efforts. So they feel that they had to try to streamline the process. And it was interesting. They said they saw their clean claim rate increase and coder productivity did skyrocket, but that was with outpatient services. So it wasn't with inpatient services. So just know there are some nuances where you still have to keep it separate. So that's really what coding is. What about what billing is? So while coders are busy translating medical records, the front-end billing process has really already started. And this is one thing that I definitely wanted to get into because billing begins when a patient registers at the office or the hospital and schedules an appointment. So from a revenue cycle perspective, getting the most accurate information up front starts with the patient scheduling and patient registration. So, that provides the groundwork by which claims can be then billed and collected in the most efficient and effective manner possible. You just have to make sure that your people at check-in, so if they're billers and financial services staff, they have to have the complete required forms, confirm they have the right information, including correct information on the patient's home address and current insurance coverage. Also, I noticed that a lot of organizations, they don't have somebody from the billing office sitting up front, which is necessary because of copayments. You need to collect copayments while the patient is in the office to make sure that you have timely collection of patient responsibility financially. A part of the front-end billing process also involves, that patient and confirming their financial responsibility. And medical billers and patient financial services staff, they need to verify that and make sure they're getting authorizations when necessary. And then once the patient checks out, they can get more information so that the coders then can do their job. Back-end billing is then with the coders and then the billers, they use codes from the information to create, we call it, or used to call it a super bill, but basically to collect that or create that itemized format to what goes on the billing form. So looking at the provider name and the location and the signature and all of that information, patient's information, visit information, data service, procedure code, diagnosis code, modifiers, times, units, quantities, authorization information. See where I'm going with this? It's not just a position that you can let go. There's front-end billing, back-end billing. It starts when the patient walks in. Then the back-end billing once the patient is gone from the office. But the coders can't do their jobs without the billers, and the billers can't do their jobs without the coders. And so it's really a collective process. And to understand that process is what's going to make you successful in this area. So why we're talking about that before I move forward, I want to talk about and say that our next sponsor would be Provide LT. Provide Locum Tenens is a physician-focused healthcare staffing forum, providing physicians a direct connection to healthcare providers and employers and their facilities. So providelt.com. Okay, so when we look at some of these services from a perspective of some errors possibly, or coding and billing, some of the common things that happen. So data entry. This is where I get into the billing office, and I really have to be patient and making sure that you train your staff. There's nothing more important than making sure you have accuracy on the billing end. And one of the biggest issues I see is lack of training. You would think that it would be, and I'm just saying this, I'm not trying to be flip or anything, but when somebody says, well, how hard can it be to input a patient's demographic information? Well, remember, patients are doing a lot of calling on the phone to get this information done. And so you might have a language barrier there and so you want to make sure that you have all the information. And patients also, when they're calling from their home to make an appointment and you're collecting that information over the phone, they may be thinking in their head, okay, well, I'm going to be giving them just my mailing address versus my physical location, but they aren't understanding that you need what is tied to their insurance card. So, for example, my physical address is not tied to my insurance card. My mailing address is, and they're different. So I want to make sure that I have secure mail. So I have it at a post office box, and then I have my physical location. That's just because I want to make sure there's no, identity fraud. There's so much out there right now. It makes me nervous. And so patients have the same thing. I want to make sure that it's in a secure place. So understanding that as far as the back end billing and the front end billing, that's the responsibility of the front end billers. Whether you're using your receptionist staff to do that or your schedulers to do that, they're actually considered part of the billing process. So you're a biller if you're actually inputting and doing data entry. But incorrect patient information, incorrect name spellings or policy numbers, that can lead to immediate denial by insurance companies. Incorrect quantities in the forms of medication, quantity given, maybe misstating the number of nights stayed by a patient in the inpatient facility, so you have a from and to be able to get paid for everything. That's definitely a problem. Now let's switch to coding errors. Now coding errors are a little bit different. So here you're looking at diagnosis and treatment mismatch. So sometimes payers will deny a claim because the coding of services fail to match. So this kind of distracted blunder can show more difficult issues with your staff. So it's really incumbent upon you to make sure that it's accurate from start to finish, right from the start. What I mean by that is recently I was doing an audit on a practice, and they just, for some reason, their coding was halted, or their reimbursement was halted, and they didn't know what was going on. They said, can you take a look? We can't figure it out. I was there an hour, and I was like, okay, well, here you go. So orthopedic practice, and they were billing for some services, and for some reason, the codes that were inputted, because there were some extra codes that were input in their system, some codes were inputted manually, and it left off a seventh digit when a seventh digit was needed. So even though you could see it on the screen, it was not picking up by the computer. And the computer didn't have a way to know it was an error. So basically it didn't say, oh, you need an extra digit. It just put in this screen. So, in the ledger of what the patient had, it even said that the bill was processed, but it didn't go anywhere because it didn't have enough digits in the actual code. So it needed a seventh digit. It only had actually 5 or 6 digits. And so it suppressed the claim, and you had to find that on the back end. But immediately when I saw it, I know exactly what was going on. I was like, okay, well, they're like, no, this says it went. I'm like, well, it's lying to you. Computers will say it went only because what happens in the hard drive or internally, they call it the file maintenance. If it's set to go, it'll say it went, but then you have to open up that back end to make sure it did go. So sometimes that's hard to understand, but sometimes it'll say it went when it didn't. And if you look at the code, and this is how you get really familiar with your codes, and you can tell that code needed another digit on it, then that's how you can kind of pick up some of that service. It's really called scrubbing. Scrubbing claims to ensure that the procedure, the diagnosis, the modifier code, they're accurate, they link, and it's appropriate for what you're doing, and you have the right number of digits. Had another practice that they put in ankle fracture for knee x-rays. Well, that's not going to pay for that. A cardiology practice that had angina for heart caths, and it seemed like their coder was giving everybody angina, but didn't realize that the doctor was also doing abdominal aortograms and doing some lower extremity runoffs, injections at the same time as a heart cath. And angina is an abnormality or a sign or symptom of chronic chest pain. And so that's not going to pay for anything you're doing in the legs. So chest pain, and, that's not going to do for it. So we're going to do well for that. So you have to be cautious with that when you have inaccurate diagnoses for the process. So that's where we have to just be really careful to make sure that not just coders, front and back end billers, but everybody is working as a kind of a team, really, to get this really accurate. Another thing for coding that I find in errors is that there's unbundling. And this happens when the provider charges related services as separate from a bill when they fall under the same medical code. And so that's more training, just knowing what is inclusive versus what you can, I hate to call it unbundle, but what you can itemize, really. And then upcoding or undercoding. So, this happens when patients' bills don't precisely speak to the services they received. And so we don't want legal action. We don't want anybody breathing down our neck saying, what are you billing for? And one of the biggest things too, and this actually is a crossover from coding and billing, not confirming what a patient's insurance covers before you perform anything. That's a denied claim. So that's not just coders and billers, but that's also, back office staff and making sure that you're getting pre-certs and authorizations, because medical billing is such an important component of a practice. Your revenue cycle depends on it. So you can see the difference there between coders and billers, and making sure that you've got the staff in the right place, who should be there. Which brings me to a question that came up that I mentioned, that, how do I transition from a biller to a coder? Well, if you've been in the billing office at least 2 years, and that's really the threshold I would say that I'd want to see, then you're ready to move, or you want to move into coding. I would have a conversation with your administrator. Now, the first kind of person I'd want to see as a coder is somebody who could work independently. Also, somebody who has good communication skills, because billers don't necessarily interact with the physicians as much as coders do. And coders also take on a lot of auditing roles. And so you're going to have some provider interactions. If you are not comfortable or get nervous or are just not feeling like you could present well to a physician, then moving into the coding office may not be for you. But if that's something that you aspire to and you want to get comfortable with it, then that's something that you should definitely consider. And so one of the things that I'm playing around with right now, I kind of mentioned it on my last podcast, and this is why I like podcasting, because I can have a conversation with you and I don't have to be as filtered. I mean, obviously I'm not going to be explicit in how I talk or anything, no profanity, even though there's some days, but I'm creating something called a Business Collective podcast. And so it's really how to transition from your current position. And just, one of the things I like is I like when people strive for more. It's called leveling up, taking things to the next level, and, not just being comfortable. Do not get comfortable where you're at, because you want to challenge yourself every day. And that's one thing I do. I surround myself with people that absolutely challenge me. And if I didn't do that, boredom would set in. That's just my personality. And so to be challenged, you want to take things to the next level. What if you're a coder that really never got involved in billing? I don't want to discount what a biller does. That could be something that you want to be an expert in Medicare. And that means you're going to have to read through regulation. You're going to have to understand what CMS is doing when they lose their mind on this new proposal. Understand that, let's say that you're in Missouri, but you have patients that are in Missouri or in Kansas and Arkansas. They're on all kinds of different states that border that state. You're going to have to know what each payer does. Let's say that you're in California and you've got Noridian, but you also have patients that maybe cross over to Arizona who have Noridian. It doesn't matter if they're in different states. You have different issues there. So what I'm trying to say is that, and I have some some recorded services or some recorded podcasts already. We're hoping to launch next month. But I want to be able to bring you a way to step out of your comfort zone. And that's why I like to talk about coding and billing and how you can step it up, how you can, let's say you've been doing this for 20 years. I've been in the industry for 32 years. I just aged myself. But since I was young, so I've been in it since I was 18. So in healthcare, and just really, actually 17. Wow, I've been in a long time. But just really stepping it up and trying to go out on your own. If you have a certain knowledge base, if you've been doing it a while and you're like, you know what, I'm ready for some freelance work. I'm ready to be a speaker. I'm ready to do that. Really embrace the medical field. It's always going to be there. It's always going to be there. And there's so many ways that you can branch out. And so keep an eye out for that. We're hoping to bring that to you in September. But in looking at the coding and billing, you can see the differences. You can see how you can move into each one. Go to your administrator, go to your physician if you're a single practice and say, I have billing background. And so not only would I like to get into coding, I would like to maybe sit for the exam and study for that. If you can help with the expense on that. If I was an employer and was going to help with the expense, I'd have you sign an agreement that you plan to stay with me for at least 2 years after I would help pay for that. So if that's not something you're willing to do, then I don't know if I'd ask them for help with that. But if they're going to put the expense in, that means they want you to stay. But that doesn't mean you would stay as a entry-level coder. It means that as you learn more and as you get more, maybe then you go up to senior coder, maybe you possibly, manager of the coding department or even billing manager, something like that. So there's ways to move within a profession dealing with or in this genre, in coding and billing. And there's only one way to go, and that's up. There's only one way to go. If you're a front office person and you want to break into medical coding and billing, this is the way to do it. Listen to these podcasts. They're free. And then, if you need more coding and more billing information from a education standpoint, that costs money. I mean, we have things. I have books on my website. We have publications, we have webinars, we have all kinds of things you can do that just give you more material because this is more listening in. But this is just to really give you that fundamental difference between coding and billing and really help you with your career in coding and billing and really let you know how important you are, not just as a coder, but as a biller, and your knowledge in this specialized field can really make such a difference. Look what I'm doing, and just, know how far you can take it. And it's just amazing to me what the medical field can really do for coders. So as we're getting towards the end, I know today I actually went a little bit longer than I thought I was going to. See how excited I get about this? But we're just at about the 30-minute point, but I want to end with a coding question. So what codes can you consider when a cardiologist provides prolonged services with direct patient contact for a patient beyond the usual E&M time? So prolonged service codes face-to-face of the office setting, those are 99354 and 99355. They're only used in the outpatient setting or office setting, and they're an add-on code to an E&M service. And so when you're coding for it, you have to be a little bit careful, only because, for example, if the patient's in a psychotherapy session, or if the patient is a COPD patient and your physician's having to maybe give them a certain medication and then watch them while they're in the office for a little bit, then that can also be, something that there's a face-to-face time element. But if you're going to add any kind of prolonged service code, you first have to meet the time threshold where it says typical time in CPT. So 99214, for example, level 4 office visit has a time threshold of 25 minutes. So if you're going to then add another 30 minutes to that, it means that that's a 55-minute visit. But let's say you met all the criteria for the level 4 service, but you didn't meet the time threshold, but you did extra prolonged care on that patient. Can you add the prolonged service code? You can't. Could you increase your level of service to a level 5 if you have that time where maybe you've met 40-minute threshold? You could. So at that point, you might just want to level up to a level 5. But prolonged service codes are very highly audited. So just make sure if you do it as an add-on that you can support the time not only for your base code, but also for your add-on code. Otherwise, that can be definitely an issue. Okay, and our last sponsor, we want to thank Medical Economics, Smarter Business, Better Patient Care, medicaleconomics.com. I love that magazine. It's a digital magazine, and they just have so much information. And yeah, I'm a little biased because I write for them, but I just love what they do, and I love having it online and being able to just access it from my phone or my iPad or my computer. So that's really helpful. So as we wrap up today, folks, don't forget my other podcast out there. It's called the Bun Life. Myself and Corinne, we just have a great time on that. If you're a working mom, professional mom, in any working fashion at all, even if you have a side business at home or anything you do, but you just want to have some fun with us about what it takes to deal with kids, not just younger kids, but adult children. I just dropped mine off today for a visit in Colorado with some of her extended family, and we had a conversation about my credit card. I bet you can tell what that was. So if you want to sympathize with that, feel free to join us on that and find us on every platform as well. So that's called The Bun Live. So hopefully you'll find us for that. But look out for the Business Collective next month in September. I'm hoping to bring that soon if you want to know how to take your career to a different level, not just in the medical field, but in any kind of business field, and how to break into being on your own. So we're going to go ahead and end today, and we'll talk to you soon. And everybody, make it a great day. Thanks for joining me today.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter at TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.